Good afternoon, everyone. It is a pleasure to have to resume this series of seminars that we call it that we hear from ECLT. And I'm very pleased, very honored to host Sven Hirsch as a speaker today. Sven is a physicist, no wonder he's a physicist. Started his career, he was educated as a physicist. He got his PhD in physics as a laser physicist. He was mentioned this to me a few minutes ago, and then he gradually shifted his interest towards a clinical application and artificial intelligence, and now he's one of the leaders in this field. He will share with us his wide expertise and wide experience on this topic. And so, Sven, without further ado, we look forward to your talk. The floor is yours.
Okay, thanks a lot, Achille. Then let me see if I can share my screen and everything works here. Here it is. Okay. So can you see my screen?
Yes, perfectly. Thank you.
Okay. All right. Then thanks a lot again for the introduction. My name is Sven Hirsch. I'm from Zurich, and there I'm as a physicist. I'm working in the interaction between say medical models and data. And what we've been specifically interested in the last 3 years is probabilistic graphical networks, or also called Bayesian networks. And I will today show you work that we've done on the way to these probabilistic graphical networks, how that all converges, and also you will see where there's some tangling ends open that we need to cover in the near future. Our main collaborator on the clinical side is the HUG, that's the hospital in the University Hospital in Geneva. And you will, during the talk, learn especially where we collaborate and why they are so valuable to us. We are working on a indication which is called intracranial aneurysms, and I will exemplify everything today on intracranial aneurysms. So right, you see painted a Circle of Willis. You see that's the carotid vessels that come from here, so come up, and then the vessels, they unite here, and you see these bulges. That is a depiction. Obviously, you don't have that many, but these cerebral aneurysms can occur on any of these locations. And usually these aneurysms that's now seeing this, the brain from below. They're all located in the Circle of Willis, in and around that. And the reason is you have, so the Circle of Willis is very important for the blood supply of the brain, because it gives collaterals, and it gives so to say redundancy in the whole blood supply. So if you have a carotid artery blocked, for example, still your whole brain is being supplied by blood, or the other one, and likewise the vertebral artery. So this redundancy helps us maintain a constant blood flow. That means if you have routes blocked, then the blood needs to go through other routes, like the internet does that. That is very, very helpful, but that also has a consequences that you have sometimes irritating flow conditions inside the Circle of Willis. And exactly in the Circle of Willis, that's where the cerebral aneurysms forms, because you have strange flow conditions. And it is thought that especially these flow conditions are the leading causes for cerebral aneurysms. These aneurysms, usually they could be balloon shaped, or sometimes they're fusiform, but it's always dilations of the blood vessel. And in the brain, 3% of the population harvest that, so it's not uncommon. And usually they remain silent, but if they rupture, then you say people have a stroke, and there's different types of strokes. There's hemorrhagic strokes, that means a bleeding, that's an aneurysm. And then there's an ischemic stroke, that means a blockage, that would be a thrombus, that's a different kind of stroke. So here we're talking about hemorrhagic strokes. And the big question that always that the clinicians have is which ones are at danger and which ones are not at danger. So when we're looking at the etiology of an aneurysm, so here you would see a segment of the Circle of Willis with the ICA going up, and then they go upstream to the anterior circulation, so that's going here. Usually you would have, when you look at the inside of the vessel, you would have an intact endothelial cell layer, then you have the so-called intra-elastin layer, then you have smooth muscle cells around that, and then you have a layer of collagen and fibroblasts that are synthesizing also collagen. So that is in the happy case. Then very often there's irritations, and when you have irritations, then you get a more leaky endothelial cell layer. Usually the elastin layer breaks, and then the smooth muscle cells, they start also synthesizing then through the fibroblast more collagen, and you see that collagen now has to take the role of the elastin because it needs to bear the load. And you have then white blood cells or macrophages that infiltrate, and then you have inflammatory processes, and then this whole thing gets more and more involved, and then it grows and grows. And so this is not like a linear process. So there could be, it's episodical. Sometimes it grows a bit and then it remains stable, and it could also have another episode, or it could also remain stable forever. So that's a bit the challenge that is there, because not every aneurysm will or would rupture. So most of them, in fact, are stable. So it could be that in this form or in this form, in the later form, they just remain there and sit there forever. And the challenge is, what is known today is that there's a lot of processes involved. You saw that in this first illustration. So there's stress factors from the outside, like hemodynamic stress, so the blood flow. You have degradations, you have aberrant flow patterns, as I told you, could be in the Circle of Willis. You have then infiltration of macrophages, you have oxidative stress, you have lipid oxidation, and so forth. So it's a cascade of biological processes that are happening and that lead to wall changes. And these wall changes in the end are then, that's what we see macroscopically in first outbulging of the blood vessel, and then at first they're small, and then they're bigger, and eventually they get more and more features, which is shown here, that they get little blebs and so forth, and then that's where for the clinicians, that's where the alarm clock strikes. If they see something like that, they always think like, this doesn't look really good. So here, sooner or later, we'll have to operate. And when you see, when we now look at what the clinician has at hand to decide, so because what they have to do, let's say at former times, and that former times is not long ago, that's 6 years ago, 7 years ago, every aneurysm was treated. And then they saw that most of the aneurysms are in fact stable, and you're better off when you don't treat, because the treatment is also associated with a high risk. So what is the state of affairs today? So the clinicians, they have to decide, do they monitor an aneurysm and do they treat an aneurysm? And today they monitor more than half, or I think 60% of the aneurysms, but then they also have to take some decisions. How do they monitor? How often do they see the patients? What medications do they give? Do they give any recommendations? Secondly, if they treat, they have to decide, do they do an invasive surgery or intravascular surgery and so forth. So there's a lot of decisions that they have to take. And so what do they have? They have some patient information and they have imaging. And that's what they have at hand to see, or to get a feeling, or to decide what to do. And the problem is that this is from 22. That's the first try of a better, more refined guideline for how to treat an aneurysm. But it's not yet, it's towards a guideline, but it's not really a guideline yet. And all of the work that I've shown you was also pre this guideline. And you will see that it also helped to evolve stuff like that. Okay, so what you need to understand so what we'll talk about today is I will tell you a bit on both imaging of aneurysms, and the second talk you will see more and more how the clinical aspects will come in. So when we're looking at the imaging of a cerebral aneurysm, when they're incidentally found or by screening, that would be done by MRA or CTA, and you can see on the left, that's an image of an MRI CTA. You can hardly see the aneurysm. The green thing here, that's the aneurysm, so it's really messy. And the resolution is not very good. If an aneurysm is at danger, then the clinicians would do a so-called 3D rotational angiography. So they would take a flat panel, infiltrate a contrast agent, and reconstruct with a cone beam then the aneurysm, and then it looks like that. You can see it beautiful, obviously. Problem being that this is a high contrast. This requires catheterization. So it's really invasive, and it's a high irradiation dose. So normally that's not done. Normally you would do an MRA, so they have to see do we treat or not treat. And then if they treat, usually they would go via the 3D angiographies. Okay, so when we are now, and so here we got inspired and see when we're looking at these 3D angiographies. You look at how these aneurysms appear. You can see that they have a multitude of formations. How they appear. They can be smaller. They can be quite regular in their bulging. They could have features, as you see here. They can have lobules. Here they can be even stronger in their lobules. And the question we had was, that was the first hypothesis we followed, is shape or irregularity, could that be a feature that tells us how at risk an aneurysm is? And there was previously also some evidence from a paper in Stroke that showed that yes, irregularity had some effect. And then our question was, how do you measure irregularity? What is irregularity? Because for the clinician, irregularity just means it's not smooth, whatever that means. So it was really, there was no quantitative measure for irregularity. It was just said ugly, basically. And so we said, the first thing that we said, let's look at that, what this means. So we are trying to get a language for irregularity. Okay, so what we did was we looked at the medical data. You saw these surfaces that we extracted, and our vision was that to take shape as a biomarker for the disease progression. So that was a big study we did with a lot of centers, and we gathered a lot of aneurysms. And so in what it was, we wanted that's what we call the morphology, so the appearance of these aneurysms. Can we do a quantitative estimation of the morphology to estimate the risk of this aneurysm? So what we did, you saw that example before. You extract it, and then you do analysis on the extracted aneurysm, and then you can you can say like, okay, is that a danger? Yes or no? Is it a rupture aneurysm? Yes or no? And then you can do machine learning on that, obviously. So what we done, then we get the data scientists get really happy, so they can now implement a lot of descriptors, and that's what we did, plenty of them, so we can extract those from the cerebral aneurysm, and we looked at, can we get a machine learning model that represents then the rupture risk best? And what we've seen here is, yes, there is it does do the job, but it gets an area under the curve of 75%. So it's okay, but not really super good. But there is evidence. So that yes, only from shape features, we can get a quite good already say a good prediction model if an aneurysm is ruptured, yes or no. You have to understand we are doing that on 3DRA. That's, you always have to understand that in brackets. That means it's not on screening data. That's why we always have an aneurysm and so a 3D replicate of it, and then we know has this aneurysm ruptured or not. And what you're trying to do is to say, can you detect that from the image? Is it a cat or a dog, so to say? And but it's not that you have an unruptured aneurysm that you can predict. That's always the underlying hypothesis from everybody in the field, that if you're able to do the one thing, then you can also predict if an unruptured one will rupture, which is not the case, though, which is a problem. Okay, so what we've seen here is, yes, there's obviously some information missing, and how can we also how can that be integrated in clinical routine? That was we struggled with that. So what we said is the next idea was we have to get closer to the clinician to tell them, to explain also what this irregularity is, because what does it help if you have a black box machine learning model? So what we said is, again, our pipeline, we can do machine learning, so we can reuse it. But what we now do is we have an expert assessment to say, is this regular or not? And then we are trying to match, do we find what is the language for irregularity? So what we did a rating tool that you can see a snapshot of that here, where we had aneurysms, and then the clinicians could say on a 10-point scale, basically, that was, is it from regular to irregular, and also some features or properties of the aneurysm that they thought would be seen here. So then what we did is we looked at, and we called this irregularity here, the slider that you have, a perceived irregularity. So it's a subjective irregularity rating. And the thing is, there's no real scale for it. I told you there's no language for irregularity. So we have like a random scale, and every clinicians could choose their scale to which they order their aneurysm, so to say. Okay, so what we've seen is when we now look at this irregularity as has been rated, we could see the subjective irregularity of the clinicians, it does relate to rupture really well already. So it's way better, it was already better than the previous machine learning or the previous model that we had. And that was, it's quite interesting to see. And when you're looking at, there is, we then looked at in terms of, does this irregularity also correlate with different features like blebs and lobules and so forth, and the yellow ones and orange ones are the ones which are significant. So yes, you can see irregularity or size correlates with rupture, but irregularity here was a bit better. Non-sphericity was a super good index to that correlated really well to rupture. And the curvature also is something that correlates really good to rupture. And the other ones, they're not so important to mention. So yeah, but what you can see that there's no real strong associations with the other factors, because it could also be that you say some blebs or lobules would be more significant for female or male. It could also be the case, or that tuberosity is more significant for smokers or not. And we just checked, is there interaction between that? And there wasn't. And so, but what we saw then, the one thing that was very strongly associated when we looked at irregularity, the different aneurysms at the different locations have a very different irregularity profile. So that's what we were able with that to teach the clinicians. So now we have, so we were able to develop a very strong model say to predict if it was a ruptured or not aneurysm, with basically two factors: an irregularity, and that could be, that was a Gaussian accumulate, and location itself. So these two factors, when you take them into account, are a real good predictor of of irregularity of rupture, and which was really surprising. So with that, we could set up a model for them to say this could be your language for irregularity, and it would add up to, say, a specificity of this. It was really interesting. Like when you look at this, what we call the psychometry model, that's so to say the properties, when you weigh the properties. And what we found is that, for example, the properties that we had was complex vasculature, rough surface, blebs, lobules, and asymmetry. They were rated, and interestingly, we found, then we looked at mixtures and found we forgot elongation, and elongation was something that we could easily capture with a metric that we could extract from the image itself. So this was like a mixture up here, which led to a very, very good model for rupture, basically. So this we were able to communicate then to the clinical community. So with that, we showed that irregularity is a better predictor than the size. And before, they always thought that size was significant, and we saw irregularity is way better a predictor than actually size. It wasn't shown in a big randomized trial yet, but there are basically no randomized trials yet for any of these scoring systems. So that's why we're no better and worse than the others. Now now we're coming to more also the data side. So that I've explained you a bit on the imaging, and now when we're seeing like, okay, what is the second thing that the clinicians have at hand, and that's these so-called scores, like phases in UIATS. Phases you will see in a second. UIATS is unruptured intracranial aneurysm treatment score. So there it's the try to set up a scoring system to say, do we have to treat a patient, yes or no? And when you see how simple that is, that's the famous, I showed you before, phases. Phases is the most known score to say how dangerous an aneurysm is. And that phases comes from the first letters of these criteria, population. So they claim, because it was seen before, that in Finnish population, the rupture risk was higher than with the Japanese, and the Caucasian was lowest. And then you had hypertension, you have age, you have the size of an aneurysm, you have earlier ruptures, and you had the site of an aneurysm. So that is the six only factors taken into account. By that, one was shown with the Cox regression that this is giving a risk profile which is increasing. So when you have phases score risks, that when you look at these cohorts, the predicted probability of aneurysm rupture rises. So that's basically the basis of how that was established. But that's the question is, does that works on a population level? And it was always doubted. It's clear that there's some evidence, but if it works for the very patient, that's a bit the problem. So also this doesn't weigh the treatment risk, for example. So that's why we said, okay, we have to go on analyzing these data. And so what we've done in this project that I've already shown you before, we've started gathering data on patients, and we have established a quite big database and I will later show you it was now also extended. And so we have a lot of imaging data, and we have a lot of merely patient data, because the imaging data is in that sense difficult, because you always have to process this. It's really laborious to extract surfaces, and plus we have this problem that we work on 3D rotational angiographies, which is suboptimal. So one of the work streams that we have is to work on MRA and CTA, but I'm not covering that in this talk. So what we've done, on this database, we've developed for the clinicians tools to more or less automatically analyze these cohorts, or that they can also set factors, and that they have like workspace, exploratory workspace to analyze these data. And it should be, and we try to give them as many intuitive representations. You just see a bit of an overview, and what I've shown, for example, to be very, very helpful to them is so-called mosaic plots. And what you can see here is, for example, you have two factors that you look at pairwise. Here, multiplicity of an aneurysm. So the lower one is the multiple aneurysms, the upper one is the solitary, so single aneurysms. And what you can see here, the colored ones is always significant, and blue means overrepresented, red means underrepresented. So males have more solitary aneurysms and females have significantly more multiple aneurysms, whatever that means. You know, so you see evidence that there is a gender difference. A second thing that you, for instance, see again with multiplicity, when you have solitary aneurysms, most solitary aneurysms are located at the communicating artery. That's the ones that connects both hemispheres in the front. The ACOM, A is for the front. And when you look at the multiples, the middle cerebral artery, which is the one that goes up, is the most prominent ones, and the PCOM, which is connecting the anterior with the posterior circulation. And that's interesting, also interesting findings, but you have to be careful with all of these findings because they sometimes underlie also from so-called screening effects. So because if somebody has a family history, for example, then you would screen for, does this person have an aneurysm? And then you could possibly also screen more not dangerous ones, obviously. And that's why then you have like screening effects that come from guidelines. So always when the clinicians, they have how they proceed with their, I don't know, clinical routine, it influences the data set that you have at hand. So you never have an unmanipulated data set, unfortunately. So what we've done with that then, in this first step with these tools that we had, we looked at this phases score to see how well it performs on an individual level. So, and what we saw is, yes, on a publication level, it reproduces the claim from the Rinker group really well. But on an individual level, it's highly risky because very many aneurysms that would be rated low risk in the end had a very high rupture risk or had a high rupture percentage. So it's not certainly not ideal. Then we went on and gathered more and more data. So and that's what the guys in Geneva do. So left, you see that's left and right is the data bank that I showed you before. They gather tissue samples, so they have a tissue database. And also what we did, the next thing is we connected to the so-called International Stroke Genetics Consortium. And the Stroke Genetics Consortium, they sequence and tissue samples, and also they collect the patient information. And what we've done in our first step, so we are the ones who analyze the pure phenomenological representation and not the genotypes. So with that, we've done the more people that you gather data, the bigger the author list gets. You can hardly recognize us in here anymore. We're somewhere here in the middle. You see my name here, and Georg, who's in my team, is up here. So we did a pooled analysis, and the bigger the data gets, and the interesting part is it's still very little data, that little factors that we have, but it gets better and better analysis, so to say. And here again, now you see how we used these mosaic plots to understand the properties of this cohort that we have in hand of this ISGC. Because here you can see is there differences between centers, because some come from screening, some have more a total population, others have looked at familial history, for example, and so forth. And that's why you can see interesting things then in there. And and always, but what you can always see, there's with this mosaic plots, you can do correlation between two factors. So you look at rupture and see, do you have more on the ruptured cases, more family history, or on the other ones, more family history? And it might be in the first case surprising that if you have a family history, you have less ruptures. But that means, because if you have a family history, then you would be screened for. That means you're better protected, because you will always, somebody will find an aneurysm and it's unruptured. That's why having a family history in this here, in this representation, is a protective factor. And so, but that is a screening effect. The same accounts, for example, with hypertension. So the question is not, do you have hypertension or not, but does the patient know that she or he has hypertension? And there it is also, if you have a hypertension, so high blood pressure is means it's less associated with rupture. And the reason being is, if somebody has high blood pressure, then if they are aware, then they probably better control their risk factors. So it's also an effect, an adverse effect. And so that's all. And another interesting finding we saw is, for example, when you have ruptures, you have much more, like current smokers, beware smokers out there, current smokers have a higher rupture risk. But if you then quit smoking, like former smokers have a way lower rupture risk. So it seems like if you quit smoking, that helps you. If you had an aneurysm before, it helps you that your aneurysm doesn't grow anymore, or that it's less at as a risk of rupture. So that means, so here, and that's then interesting when you look at that, because you always have to go point by point and say, what is the screening effect, and what is possibly something that we could take as a suggestion also to our patients. And the right one is for sure an important suggestion: quit smoke. If you have an aneurysm, quit smoking. And there's other things that, for example, weren't significant. So here, for example, you saw there was no on the left, there was no significant difference between different populations. Interesting. I think I should skip over that, or just record that. So what we did also is look, is there regression models for that on this bigger database, just to see what is the importance of different factors. And that's how the clinicians look at that, at odds ratios for certain factors. But the question and the difficulties, and that's where I'm coming to the next step, is when we're looking at these risk factors, when we have a scoring system, that's the underlying assumption that they're independent. And when you're looking at now the factors and do a independent study, you see that they're highly correlated, these factors. So that means the assumption is not satisfied. So that means you have a lot of interacting factors that in the end lead to a rupture risk. And the question is, what is this interaction now? First, I do an excursus where I tell you that you see that there's some dynamics, and then I will come to this interaction part. So the one thing we did that was an interesting idea. We thought, you know, why not? We need to get a better time view of aneurysms. So what we said is, what is the time course of an aneurysm? And you don't know what it is for a single one, because we only know, is an aneurysm, did somebody have an aneurysm, yes or no, how big it is and so forth, and how old is the person, but we never know how long will somebody have an aneurysm, because, you know, either the person is treated or not treated, the person dies before, or you don't know when they got it, and so forth. So when you're looking at the time from birth to death, if you get an aneurysm, then it would form at some time point, not at your birth, but sometimes later. And it could rupture in your lifetime if you're an unhappy person. But it could also, basically, it could form and it could not rupture, or you observe it now and it could rupture later, or you observe it now and it could never rupture. Both could obviously happen, but we don't know that for the individual patient. So what we don't have a cross-sectional, we just have a cross-sectional data and no longitudinal data set. And also we have no information when the aneurysm formed. So what we did, we made a simplified analysis or assumption that simply the age of the person represents the age of the aneurysm. So we basically do as if the aneurysm was developing since birth, which is wrong, but you will see that it's quite useful that we do that. So what we will do now, or what I will show you, is a couple of examples for Kaplan-Meier analysis, which is a, so to say, a survival analysis to understand this plot here. So here 1.0 means all of the aneurysms are intact. And then you see as soon as an aneurysm, you look at the age, so you order them by age, the patients. And then as soon as an aneurysm is ruptured, then it would go, it would give a tick below. And so the number of aneurysms accumulate that rupture from top to bottom. And here in the end, you have, what is it, 30% of the aneurysm still intact, and you have the other 70% that has ruptured by that time point. When you are now looking, the interesting part is, and here you're coming to personalization, when we're looking at different strata, so different stratifications of patient cohorts, when you're looking now differences between the sexes, male and female, what you can see here, the onset of rupture events is in females several years later than in males. That you don't know when the onset of the disease is, but you know the onset of rupture events is different. But when you look at the inclination then is the same. They split, interestingly enough, they also split here, and that also correlates quite well to the hypothesis that in menopause there's changes in the hormonal system, and that will influence also the wall integrity, for example. Second one, here you see, for example, the family history. That's the screening effect that we saw. Interesting, like the modifiable risk factors, you can see differences between smokers and non-smokers. You can also beautifully see then also the differences if somebody is hypertension aware, yes or no, and how the dynamics of the disease are different. One interesting part is also when you're looking at different risk locations. Philippe, that's our clinician. He has, they have like a scaling that PCOMs and ACOMs are high risk, MCAs are mid risk, and the others are the rest. And if you do that and you're looking at the age, for example, so the onset of rupture, you can see that, for example, that's the red and the orange are the medium and the high risk locations. You can see that they have pretty much the same onset, and that at a very later age or a higher age that they split. And then the risk of rupture from 55 on is in high risk locations way higher than it is in mid risk locations. Whereas when you see low risk locations, the risk remains for very long quite low, and then it has a steep descent, so to say. And that's all. And I found it quite interesting that, you know, things like that, the stratifications, they help the clinicians a lot in their hypothesis building. And so that's how we went on. And currently we're exploring this, say, way to get more like time evolution. But before I now come to the last part, which is a network disease model. So now I'm looking at, we have this question of the interactions between the different factors, and the question, and we said, what is a way to capture that and how can we learn it? And what you can use is so-called Bayesian networks or belief network, causal networks. They're probabilistic graphical networks, very often, or usually they're directed acyclic graphs, so you shouldn't have any closed circles in there. And what they're known since the 80s, and you can use them quite well for knowledge generation. So what you do is you take your data, and from the data, you first learn a structure that represents these connections best. The thing is, it depends on the samples from these data that you take. And then you estimate parameters on that, and then you have a result which best represents this sample. Okay, so how that goes is first you have you have a fully connected graph, and then you can say you can bend some arcs by reasoning. And here what we had, for example, when you're looking at smoking can have no influence if somebody is male or female. But yes, it could be that the smoking, that the gender females smoke more than men, for example. So here what you can do is you can blacklist arcs which are not possible. That's the first thing. So you can forbid them. And then when you have that, then you can do a structure learning. And with the structure learning, you always take samples of the complete data set. You learn on them a structure, and then you see what the optimal, what this outcome is. And then you take a next sample and test it, and take the next sample and test it. And then you have to combine these samples again. I'm not explaining that part. It's a bit too much, I think, for today. Okay. Okay, so then you have a structure, and then what you then can do with the Markov chain Monte Carlo, you can also correct for overfitting or see how you balance the combination of the different samples out. So that means then you also throw away some arcs, and then the last step, what you do is you take your data and fit them to exactly that network that you found, and you learn what is the conditional probabilities then on this one. And when you have that, then you have, so to say, then you have a network graph. And so what we did, so one of the ideas that we had is that we had a hierarchical risk factor influence on the ICA, which meant that we had a structure which arcs were banned. So we had a systematic logic for that, which helped in the blacklisting process. And that's one little details for these probabilistic graphical networks. There's basically two types. Left, that means you subdivide. You have H, for example, and you subdivide H in H groups. Then you have the challenge that you have to find the good set of number of groups and what is a good segmentation. The right one is a different representation. It's called additive Bayesian networks. And what you do is you take your distributions as metric, and you can use you can reproduce them by normal distributions, for example, or modified normal distributions. And then this is more like a generalized linear model. They also in the end look like a Bayesian network. But the important part is you can here handle metric data. With the left one, you can, but you have to bin them. And then, so what we do, so for this whole binning, so what we do, we take this data and we harmonize them. Then you need to do some binning for the left case, for the right case, you don't. And then you can see, and that's then an outcome of your structure. And here that's just exemplary. Here you can see that's a multinomial, that's these faceted boxes, these polygons in that sense. And here you always know that's a discrete Bayesian network because it's multinomial. If it's a metric factor, then it would be a blob. You will see that later on. And what you can here now see, you have a completely different representation of your factors. And yes, you can still see they're connected, but they have they are independently connected now and not directly connected, like in the phase score where you just mixed all of them. And when you are, so what we've done to see, does that make sense, what we have, you can look at the individual correlations, like chi-squared correlations between these risk factors. And when you are looking at, for instance, like when you're looking at the correlation between age and rupture, you can't see a direct correlation, but what you can see, you can step through that. You can see age is correlated with hypertension. And then let me see what the next one is. Hypertension here. I'm going through that one that I find interesting. So age is correlated to hypertension. Hypertension again is correlated to multiplicity, that is here, because you have so here you see age is, oh, pardon me. no, back. There was too many animations here. Here. You see age here is correlated to hypertension. And then you see hypertension is correlated to multiplicity. And then here you can see multiplicity, where here multiplicity is correlated to size, and then you can see size is correlated to rupture. So what you can see when you step through this correlation matrix, so yes, it is also there. But from a pure correlation, you would also see that an age would obviously be also correlated to rupture if you just look at the individual factors. But if you look at it with the dependencies, it also works. And that is quite interesting. So what we've seen, so here now, that's a representation, that's where I showed with these blobs. The blobs mean that this is now an additive Bayesian network, which represents a metric. So what we've seen is that with we could now learn this network of risk factors, how they act upon here the rupture risk. And what we've done is what we see is that there only here now in this model only two factors actually directly influence the rupture, and that is the location, and that I've told you that before. That's a very important one. And here we have size. And size, we've learned before, would probably be a proxy for irregularity. So if you would have irregularity in, which we don't have yet, then this would be basically in between. Also, we see this staging basically of these risk factors. And also we see that some factors, for example, smoking is not directly linked, but smoking would be indirectly linked here via age, for example, or via sex. Would be indirectly linked to rupture, but not directly linked. And so all in the end, we were able here with this dependency structure, we were able to reproduce all of the expected, so the knowledge that the clinicians have and that they previously, I told you with these Mosaic plots, where you go through, iterate through all of these individual combinations, you could see everything compressed in one image here. And there was nothing there was some surprising findings because we saw the indirect links, but nothing was missing. That was the interesting part that we got out of that. And I'm not going through the details through that now, because I think I slowly have to come to an end. And what we did because when you have this graph, what is the interesting part is you can compare that also to a normal prediction model like the one that we had before. You can just see, does it reproduce that well? And it performed equally well in terms of a prediction score. But in terms of a pathway, it's obviously much better for the clinician because there they understand the logic of the importance of the individual factors, obviously. So yes, we did this validation test with a linear regression model. And what you can now do, and that's the interesting part with this Bayesian model, you can now lock different nodes. You can say, oh, if age now 25 and smoking is former smoker, then you can do a propagation through the network and see what is now the probability of this aneurysm being, that this aneurysm should rupture, yes or no. So that means you can do a belief propagation through this network then, if you've learned it. So it's like a beautiful machine that can now give you predictions in the end. And what we have to now do is to validate that on a bigger data set. And so that's basically the final thing where we are currently. So here you see the publication of this latter work that we have. And yes, currently we're working on a multicentric study with the ISGC consortium. So as conclusions, I can give you disease specific for the we were able to identify with this machine learning method that irregularity is an important factor for in risk, which is not in the risk scheme now. What we've seen is obviously models need to be explainable, otherwise they will not be really adapted. And that's why the clinicians usually reside on their factor models, which are explainable but not good. What we saw is that these results from the Bayesian network analysis, it reproduces the existing evidence, and we could propose a network model from that. We need to go to dynamic processes. That's what we're currently working on. And you saw, and what we always saw is that a good reference data set, that's the most difficult part, and have longitudinal data sets. There is no such thing as unbiased data sets in clinical practice, but at least we have to try to understand always where the biases are and take them into account, because otherwise these results are really misleading. With that, I'm finished. I'd just like to thank my team, especially the whole team of collaborators that have contributed to these efforts. And with that, I think we can still have time for several questions.
Yeah, thank you, Sven. This is a virtual clap on behalf of the whole audience.
Okay.
So I find this very interesting. Thank you very much. I do have multiple questions, but I want to leave to ask whether anyone else in the audience has questions. Otherwise, please use